Hi, good afternoon. My name is Glenn Kerr, and I'm an adult hip and knee reconstruction specialist. I work at Westchester with OrthoVirginia, and just pleased to be here today, and thank you for joining me. I'm fellowship trained in adult hip and knee reconstruction. I've been doing these types of surgeries for about 13 years here in Richmond. I recently, about 6 years ago, switched over to robotic assisted surgery. I've done just over 3,000 hip and knee reconstructions, and just thrilled to meet and see new patients. One of the most commonly asked questions that I get when it comes to total knee replacements is, which approach do I use for knee replacement surgery? And that question kind of started my talk or stimulated my talk today. And so I want to talk a little bit about the different approaches to the knee. As an overview, there are three major described approaches to the knee. I'll talk a little bit about the literature, specifically one study that kind of launched the approaches to the knee. And then we're going to talk a little bit about outcomes and how patients do over the longer term at 10 and 15 years with the different approaches. And then finally, I'll finish off a little bit with robotics and approaches and kind of the do's and don'ts when it comes to that. So the first approach, this is called the medial parapatellar approach. And this is the workhorse of total knee replacements. If you have known somebody that had a knee replacement 5 years ago or more, it is very, very likely that they had this approach to the knee replacement. So some of the pros to this approach is that it allows for easy eversion of the patella. So your kneecap during the surgery is turned to the side during the surgery. And we think that might be one of the reasons that total knee replacement surgery that some patients have pain afterwards. But this one allows for easy eversion of the patella. And that's important when we're talking about approaches. There's an ability to extend the approach. And this is particularly important when it comes to revision surgery. And then the exposure and training that almost all residents that have been trained in hip and knee replacement will be exposed to this approach. I think some are exposed to other approaches such as the midvastus and subvastus that we'll talk about. Some of the cons to this approach, the geniculate arteries, and this is the arterial blood supply of the knee, could be damaged during this approach, particularly on the inside or the medial aspect of the knee. The saphenous nerve is an infracranial branch of the saphenous nerve, is a nerve that runs from the inside of the knee to the outside of the knee, and it's at risk almost with all approaches. And then the recovery, we're going to talk a little bit about that. So the midvastus approach is one, I don't know a surgeon specifically that is still doing or has done this approach. This is not one that I was trained with in surgery, but it's one that's described. It splits the muscle fibers. And so one of the pros may be that it does not violate the quadriceps tendon. So it's very similar to the subvastus and that, but it does have a number of cons. And the first one is that it does cut muscle fibers. And so I think that's the reason that most surgeons would avoid this. It's not extensile. I mean, you can't use this for better visualization for revision surgery, and it may still damage the geniculate artery. So the next approach is the subvastus approach, and this is the one that I think many patients have heard about and have questions about, and probably the reason that the majority of people are watching this presentation today is this approach and how we do it. It's from the side of the knee, and it goes underneath the muscle belly of the vastus medialis obliquus muscle. It does not cut through the muscle itself, unlike the midvastus. And there are some of the pros that preserves the geniculate artery, and there are some studies that would suggest a faster recovery, particularly in the first 1 or 2 weeks. The cons, and these can be big ones, it's not extensile. So this is not an approach that we could use for revision surgery. It's very difficult to expose the kneecap and allow for removal of the osteophytes on the outside of the knee. So we're coming at the knee from the inside and to resurface the kneecap. And there are some patients that come in specifically for issues related to their kneecap. It can be very difficult, particularly if the kneecap is difficult to mobilize with this approach. And the exposure is dependent on the patella. So if you cannot move that patella side to side, it's very difficult to do this exposure. So I want to move on to the literature, and there was one study that kind of stood out that was published back in 2001 by a guy named Rosam that looked at the subvastus approach, and this was a randomized, prospective, study where they randomly selected people, and they had 43 in the regular medial parapatellar group and 46, I believe, in the subvastus group. And they compared them when it came to things like pain control. And it was found in this study, kind of in the short term, that those that had a subvastus approach had less pain. And the next one, they looked at the motion and measured how well patients could move. And these two things, pain and motion, after the surgery go together, but the early motion favored the subvastus approach. And the third thing they looked at was the length of the hospital stay. And it's interesting, this study was done in 2001. So the good length of hospital stay was 3.2 days. And the bad one, which was the medial parapatellar, was 5.8 days. And that's much longer than almost anybody stays in the hospital after a knee replacement surgery. So that was kind of dated. As we move on, I want to talk a lot about outcomes. There are a number of different studies, and the first one that I'd like to talk about was by a guy named Matazabi. This was done in 2024. They looked at the World Expert Meeting, and this is a meeting of people who were fellowship trained in hip and knee replacement, and they were all given a task. They came together during this meeting, and I don't know how many participants they had, but they reviewed the literature looking at these different approaches, and what they found is there wasn't really a statistical or relevant difference in the early functional outcomes within 6 months post-surgery when comparing the different approaches to the medial parapatellar. So they didn't really find a difference, and this was done in 2024. The next one was done in 2021. This was done by Bucci, and this was a meta-analysis to look at a number of different studies. And what they did is combined over 60 studies to increase the numbers of patients that we're looking at. I think they had just over 5,000 patients to look at these different approaches and which one allowed for better mobilization. And they looked at all studied surgical approaches for toe knee replacement were equal. So they didn't find a difference in one approach versus the other. And the last one was a comparison of the vascularity and the blood supply to the kneecap. And so as I mentioned, the geniculate arteries. And so these are arteries that come from the inside of the knee. That's one drawback of the medial parapatellar approach. And those geniculate arteries, when they were studied in anterior knee pain, they found that the subvastus approach, abbreviated SVA, appears to offer no benefit over the medial parapatellar approach in terms of the vascularity or the anterior knee pain. So patients had mainly the same amount of pain afterwards. And so some of the older studies in 2014, Brian Curtin looked at the pain after the surgery. And this was not a randomized study, but he looked at 546 patients undergoing a knee replacement. And he compared this to 255 patients that were done with the subvastus approach and found that those in his group anyhow had less pain with the subvastus approach. Another study done in 2009 by Bork demonstrated that the systematic review of the literature looking at the medial parapatellar versus the subvastus showed no statistical difference. And that's kind of similar to these other studies. There just hasn't been borne out, especially long-term at 6 months, a year, or 18 months, marked difference between the two. And the final study, this one was done in 2014, looking at this is another meta-analysis looking at whether or not the subvastus or the medial parapatellar showed any benefit. And they did find, when they compared all these studies back in 2014, that there were some improved early outcomes. And the summary of these clinical outcome studies is that many of them have not found a marked difference in the approach. Some of them have found an early improved outcome with the subvastus approach, that some patients have better pain control on less than that. So finally, I want to talk a little bit about robotics and approaches. And I do 100% robotic hip and knee replacements. Meaning if I do a knee replacement, it's done robotically. And the first thing I want to point out is this can be used with any approach, that it is not dependent on the approach. I don't do a robotic surgery in some patients and not a robotic in others, depending on the approach. The second point is that there are safeguards, and this is super important, that when the surgeon is doing this with a manual technique, there are no safeguards. But when you do it robotically, there's a lot of safeguards, particularly if you're using the subvastus approach and having difficulty seeing over on the lateral aspect. There's no issues with the safety of the resection of bone. The third point is that it allows the surgeon to assess the balance and alignment. And I think this is very fundamental to robotic surgery. This is all about the precision the accuracy and the reproducibility of the surgery. And so that's why I do robotics, and the ability as a surgeon to look at that knee and decide whether or not it's balanced. The same as if you bought new tires for your car, you'd want to make sure they were balanced. Before you drove that car, you want to make sure that knee is balanced and that it's perfect. And I want to go out to the waiting area and talk to the husband or wife and tell them this knee is perfectly balanced. And also the alignment of the knee, that I can look visually at the screen and really tell exactly what that functional and mechanical alignment of the knee is following that. Longer term outcomes, we're at a point with robotics. This was new technology years ago, but we're approaching about 12 or 13 years, particularly with the partial knee replacements, that just show a marked improvement in both the alignment of the implants as well as the long-term survivability of the implants. And so there are that I look at as contraindications for doing a subvastus approach. And the first one is when a patient comes in and they have anterior knee pain, and I know going into that surgery, the number one reason for doing that surgery is for anterior knee pain, that we're going to have to resurface that patella. There's always a question about that with the subvastus, and there's not with the medial parapatellar. And so I would talk with patients individually. This is something that we would kind of make a decision jointly prior to the surgery. The next relative contraindications is an elevated BMI. So the body mass index for bigger patients, it can be very difficult. There's one study that suggests thigh circumference is correlated with poor outcomes utilizing the subvastus approach. And in those patients, I'd use the medial parapatellar. Next one, knee flexion. So if you cannot bend the knee beyond 90 degrees prior to the surgery, this is a relative contraindication. The subvastus approach is dependent on the mobility and flexibility of the vastus medialis obliquus muscle. And if you don't have good knee flexion before, you're not going to have good mobility of that muscle by the time of surgery, and it's going to markedly limit the exposure. The final one is patellar mobility, that if a patella does not move side to side before the surgery, it's going to give us a great deal of difficulty with the exposure at the time of surgery, and a better, more extensile exposure is the median or medial parapatellar exposure. I wanted to conclude, there is an overview, the 3 points I'd like you to take home. There's some evidence for early recovery when it comes to subvastus procedures, and that's likely due to the amount of patellar eversion that is done. Many times with a subvastus approach, patella may not be resurfaced, the patella may not be everted, and the patient has less pain because of that. There's no clinical difference in long-term follow-up. So you didn't get kind of a different deal than the next person. Your approach isn't going to predict how well that knee functions and how you're doing at 6 months. The literature would support that almost all approaches are fairly equal when it comes to 6 month, 1 year, and 18-month follow-up. And the final point would be that robotic assistance can be used for either approach, that I would be thrilled to see anybody. Robotic surgery is not approach dependent, and I can easily utilize it and am very facile in both the medial parapatellar and the subvastus approaches. And that would be that. So I want to just thank those that are listening for joining me today. This is a picture of my family, and I have my beautiful wife and my mom is just to my right there. Then I've got 3 wonderful children, and I just wanted to open it up for any questions that people may have and do my best to answer those.
Thank you so much, Dr. Kerr. So we will be answering questions that were submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will be getting through as many as we can. So our first question is there a maximum age for knee replacement, and is there a minimum age for knee replacement?
Great question. So I do not have a maximum in mind. I would share a real quick story about a young lady that I did that was 96 years of age. I did her hip replacement, not knee replacement. And she finally put her foot down and said, I'm going to have this surgery done. And she was 101 last time I saw her. She's had 5 years where she's been functioning well. And I learned an important lesson that I would kind of defer to the patients and their medical problems when it comes to a maximal age. And so I wouldn't limit it based on that minimum age. The younger the patients are, the more time I would spend counseling them, the more likely they would need some type of revision surgery. So I do not have a fixed maximum or minimum.
Thank you. How long is recovery after knee replacement surgery?
This is a great question. And so the most important aspect of how you do after the surgery is not the surgeon or the approach, but it's your level of fitness before the surgery. And so let's take somebody that was, say, an Olympic athlete before the surgery. My expectations in there should be a very, very fast recovery. Somebody that may have had some medical issues like a heart attack before, several stents, and really hasn't been able to mobilize or do much is going to have a longer recovery. So the level of fitness of the patient and their activity level before the surgery will have everything to do with the recovery after the surgery.
Thank you. Can a patient have a Baker's cyst removed at the same time as knee replacement surgery?
Yes. And so there's a wonderful study. I've been asked this question several times to look at Baker's cysts and what percentage of time they recur after the surgery. The cyst itself represents kind of a potential area, and this is an area of low pressure. So joint fluid produced secondary to the arthritis accumulates in the back of the knee in a low pressure environment, and we call that area of accumulation a Baker's cyst back there. These are spontaneously decompressed often during the surgery. This study, it was surprising to me when I read the results to look at the number of times that a Baker's cyst comes back. It's about 50%. So we don't, and other surgeons may be able to speak to this a little bit differently, but we wouldn't go in specifically to resect a Baker's cyst. And this is a posterior structure, and all the approaches that I listed are coming from the front of the knee. So getting at the Baker's cyst and really addressing the issue, and really the number one reason you have a Baker's cyst is because you have knee arthritis, and that knee arthritis leads to excessive generation of joint fluid and bleeding, and that accumulates in the Baker's cyst and it expands. Once the arthritis is removed, that Baker's cyst gets better.
Thank you. Is the scar less noticeable in one approach versus another?
So the scar is going to be relatively the same. Some people, there was a huge craze probably 10 years ago, maybe a little bit longer, of minimally invasive surgery where we shortened the length of the scar. And I use the analogy of if you took your car to the mechanic and said, you can only open the hood 10 inches and you have to replace the engine through this versus being able to open the hood completely. The scar, so the length of the incision has nothing to do with outcomes, but as that incision gets too small, it will definitely affect the clinical outcomes. And we did several studies on that looked at how patients do, and we found that malalignment of the implants was correlated as a scar got too small. The number one factor in how a scar is going to heal is going to be patient dependent. If patients have had old scars from a previous surgery or from a laceration that healed with keloid, then that might be a very good predictor that they're going to have some keloid formation after their toe knee incision. For those that heal very well with other surgeries or other lacerations, they're going to heal it very well. I tell all patients you must avoid UV light exposure over the first 6 months to 1 year to avoid pigmentation of that scar, and it'll blend in with the normal skin tone after that.
Thank you. If someone is obese, do they need to lose weight before having a knee replacement?
Absolutely. There are correlations to look at body mass index and how patients do following surgery, and those that are able to lose weight prior to the surgery will have a much, much easier recovery than those that do not. So the weight loss can be correlated with outcomes and function after the surgery. I encourage everyone. No one would come to see me today and say, Dr. Kerr, please sign me up for a weighted vest that weighs 5 or 10 or 15 pounds and that'll make my knee better. We intuitively know that as we remove that weight, as you lose weight, that it's going to functionally, you're going to do better with the arthritis, but functionally you'll do better with the recovery following a knee replacement. So I always will encourage patients to work on weight loss. Nobody knows it better than this guy, that it's hard to do, and it's something that I spend a lot of time talking to patients about.
Thank you. What are knee replacements made out of?
That's it. So two things. The thigh component of the knee replacement is made out of cobalt chrome. The lower leg portion of that knee replacement is made out of titanium, and the spacer in between is made out of a real high-grade plastic called polyethylene that adds that. And all knee replacements use these same materials in different degrees at all major manufacturers. I use a Stryker triathlon knee replacement, but I think that all the other major manufacturers, cobalt chrome for the thigh portion or the femur, titanium for the lower leg portion, and then polyethylene as the spacer.
Thank you. Are there restrictions on activities after knee replacement? And are there different restrictions with different approaches?
So I do not have different restrictions based on the approach. That's different than hip replacement surgery. I do a lot of direct anteriors where they have very much fewer restrictions. The restrictions for both hips and knees are very similar afterwards, the side-to-side cutting movements. And so one of the visual things that I encourage patients to think about would be singles tennis should be avoided. But the inline activities, walking, biking, hiking, elliptical trainer, swimming in a pool, those things should be fine after the knee replacement surgery. But I do not have different limitations based on the approach.
Thank you. Can more damage be done if you don't get a knee replacement when the doctor says that you need one?
That's a great question. And so what I would say is that it's very unlikely that you're going to do more damage to the knee itself, but you're going to be more sedentary, that you're going to watch more Netflix, you're going to do less walking, less activity, you'll decide to do less with your family if you don't have that knee replacement done. And so age becomes a factor. Sometimes people say, I'm too young for a knee replacement, but if that equals them sitting and watching Netflix and not getting out of the house and doing things that they normally would do, that more damage may be done to the heart and lungs than to the joint or articular surface. And that I know of, no one has ever had such bad arthritis that we could not do surgery. So it doesn't usually progress to that. And so the opportunity cost or the cost lost with not doing activities because of the knee arthritis is the big thing to take into consideration when it comes to that.
Thank you. Do you recommend getting a second opinion before committing to surgery?
I do. And two things. I think that I would always encourage somebody that you have to be very comfortable with the surgeon doing the surgery. And if you have any questions or any concerns, I think a second opinion is a wonderful thing. So I would encourage patients to seek that out if they feel uncertain about the decision for surgery or the surgeon itself. And just to speak to this briefly, I tell patients, you're driving, I'm the passenger. You tell me when it's time to have an elective surgery like a knee replacement rather than me telling you that it's time to have the surgery done. So I think the patients need to reach that decision. If they don't feel comfortable, a second opinion is something I would encourage, and it can be a wonderful thing.
Thank you so much, Dr. Kerr. That is all the questions for today. Would you like to close?
I would. I want to thank everybody for being here and taking the time. I'd be thrilled to talk with people individually, and you can make an appointment to see me at Westchester. And just thank you for being here today. I greatly appreciate it. Hope you have a great day.